Assalamu alaikum, and a very warm welcome to all our distinguished guests and participants. This is Ra'al Hathi, the Vice President of the Saudi Society of Dermatology and Dermatological Surgery, and the head of Riyadh Bid File to host the World Congress of Dermatology 2031. It's an honor to welcome you to this historic first session of the first Saudi Africa Summit. We gather today in a spirit of a partnership, recognizing the immense potential that lies in strengthening the bonds between the Kingdom of Saudi Arabia and the vibrant nations of the African continent. This summit is more than a meeting. It's a bridge for dialogue, a platform for shared vision, and a testament to our collective ambition for growth, innovation, and sustainable development. As many of you know, Saudi Arabia is energized by the transformative vision, a spirit captured in our bid to host WCD 2031, the Riyadh Fide. This bid symbolizes our national ambition to welcome the word, to build lasting legacies, and to create unforgettable experiences that unite people and cultures. We see this same spirit of connection and opportunity in our relationship with Africa. None of this valuable dialogue would have been possible without the dedicated efforts of our friend, Dr. Najib Dose. A special and a heartfelt thank you for orchestrating this summit. Dr. Najib, your leadership and vision have been instrumental in bringing us all together today. I also would like to extend my sincere gratitude to our esteemed speaker. You have generously taken time from your demanding schedules to share your invaluable insights and expertise with us. Your presence is the cornerstone of this collaboration, and we are deeply grateful. To all our participants joining from across Saudi Arabia, Africa, and the globe, thank you for being with us today. And let us now embark on these discussions with open minds and a shared purpose. I'm confident that the connections we forge and the ideas we share today will pave the way for a stronger, more prosperous future for all our people. Thank you, and let's start with our first speaker, a brilliant speaker from Saudi Arabia, Dr. Azzam Al Khalifa, a professor with subspecialty and special interest in nail disorders. Dr. Azzam, please start.
Hello, good morning all, and thank you for the kind invitation. I've just shared the screen, and I'm happy to collaborate with the Saudi Society and the Saudi WCD bid is collaborating with Africa. I know we have great minds in Africa, great experiences in white skin and dark skin, so we will learn a lot from this session and the coming sessions. I'll start with talking about nails. You know, these pieces of nails that we throw are full of information. Please let me know if you don't see the screen. These pieces are full of information. When you throw them, you can analyze them and to get a lot of information about diseases, about the health of the person. And of course, it is much easier, much less painful than the biopsy. We would love one day to replace the biopsies with clipping, but we are still far from that. Biopsy brings detailed picture about what is happening in the matrix, what is happening in the nail bed, but we can see the light at the end of the tunnel. We can see now more and more studies about clipping and how to use clipping instead of biopsy. Imagine if you have a patient with nail disorder in your clinic and you need a biopsy to know the diagnosis. This lecture is meant to explain when can you use the clipping, the simple clipping, just to cut the nail, and you can get the diagnosis instead of doing the biopsy. In old patients, in young patients, in some complicated cases, you don't want to do the biopsy and the healing time. For the biopsy, you need anesthesia, and the anesthesia itself is painful. It takes time. And for clipping, you don't need all that. Then the biopsy, it is a surgical procedure. It needs a healing time of 2 to 3 weeks. And there is always the risk of a definitive scar in the nail with a biopsy, especially when you touch the matrix and specifically proximal matrix. So clipping is much, much, much easier if we can use it properly. I will start to talk about different disorders that we can use clipping for. And clipping is just to cut the end of the nail and to get a picture of what is happening here in the matrix. You know already that proximal is the surface of the nail, distal matrix is the lower side of the nail. So we can get a picture of what is happening here, but it is not as detailed as here because you don't have cells here. You have only onychocytes and proteins. This is an example, a common example in our clinics to receive a patient with yellow nails. Is it psoriasis? Is it fungal infection? I believe it is psoriasis, but if you have a patient where you do not know is it psoriasis or onychomycosis, you might do a culture, false negative culture. You can do a biopsy, but you can do clipping and histopathology, and this will help much in the diagnosis. This is an example, reported patient with yellowish nails, onycholysis, and they did clipping, and histopathology of the clipping shows nail thickening and keratosis, and it shows also parakeratosis and neutrophils. So we think it is psoriasis, but you have to know that all these signs also happen in onychomycosis. We have thickening, we have keratosis, we have parakeratosis, and we have neutrophils. Here another patient, yellowish nail, is it psoriasis? We have the erythematous border, but it could also be onychomycosis. They did clipping, again, the same exact signs, thickening, subungual keratosis, parakeratosis, and neutrophils. Of course, if you do the PAS stain and you get the filaments, as in this case, you confirm that it is onychomycosis. But you see that histopathologic signs are similar in onychomycosis and psoriasis. And here comes this interesting study of retrospective analysis of nail clipping, more than 100 patients comparing onychomycosis and psoriasis. And they found that both have parakeratosis, here neutrophils and here parakeratosis, and they categorized them into scattered aggregated collections, just like mild, moderate, severe. And here again, like mild, moderate, severe, very severe. So in neutrophils, they found that onychomycosis, most of the patients, 60%, they have severe or collections of neutrophils. While in psoriasis, most of them, they have aggregated neutrophils. So we have more neutrophils on onychomycosis and more parakeratosis in psoriasis. In onychomycosis, only few patients had confluent parakeratosis, while in psoriasis, more than a quarter and more than a quarter with columnar parakeratosis. So between onychomycosis and psoriasis, more parakeratosis in psoriasis because it is a keratosis disorder, and more neutrophils in onychomycosis. And of course, the PAS stain is the gold standard. But also, if you are doing culture and KOH, in my patients, when I receive a patient and I think it is onychomycosis, I cut the nail, I send for culture and KOH. But now comes these studies that show that culture has a sensitivity of 53%, 33%, 49%, 29% for different categories of patients. So highest sensitivity is 50%, which means that half of your patients will get a false negative with nail culture. So it is not very sensitive for the diagnosis of onychomycosis if you do culture alone. Of course, it is better if we do KOH also, but more cost, and you need a trained specialist to do the KOH and the culture and to read them. But with histopathology, PAS stain, you have a sensitivity of more than 80%, 88%, 93%, and 88%. The same group of patients. So PAS stain in histopathology is much, much more sensitive than culture. So if you have a patient and you do culture, it is negative, and he comes back and you still think that it is onychomycosis, just do clipping and send it for histopathology for staining, and this will show if it is onychomycosis. But of course, you have to take a representative clipping. You can see in this patient that the stain of Trichophyton rubrum stops here. So the living fungi are all here in the proximal part, but the distal part has no stain. So if you do clipping, whether it is for histopathology or for culture, if you do clipping only of the distal part, you might miss the diagnosis. So if you do clipping, you do proper clipping. You try to get the proximal part of the nail, and even if there is a powder under the nail, this powder should be sent for culture and KOH, because here lives the fungi. So always proper clipping For histopathology, you need at least 4 millimeters to have a valid piece for the preparation of the slides. So for onychomycosis and psoriasis, we can use clipping. Onychomatricoma, of course, you can use clipping. It is very representative. You can see the cavities filled with serous fluid, and with staining, you confirm that it is lined with epithelium. But of course, in onychomatricoma, you can detect it with dermoscopy or even when looking at the distal end of the nail. But in some starting cases, you can use the clipping. Another indication is the pigmented nail. Here you have 7 patients. I will give you 10 seconds to think how many of these patients have a real melanocytic lesion, whether it is benign or malignant, but it is melanocytic. So 7 patients, let's take them one by one. The first one, look at it. Do you think it is melanocytic? Could be. Second one, well, again, could be, but there is surface alteration, maybe not. Third one, could be, but the purple color and there is no clear lines. This could be a hematoma. I think this is hematoma, and it is hematoma. And here it could be melanocytic. It could be melanocytic. It could be melanocytic. It could be melanocytic. Especially in our skin types in Africa and the Middle East, our skin type pigments a lot. And we see a lot of patients with pigmented lesions. But when we take these cases one by one, this was onychomycosis. This wasn't melanocytic. And we know that there are some studies showing that some species of trichophyton and other fungi can produce melanin, and they can activate melanocytes in the matrix. So it's 2 sources of melanin. So this was onychomycosis. It doesn't look like onychomycosis. Here it was onychomatricoma, not melanocytic. Here it was hematoma. Here it was pigmented onychopapilloma. Here it was onychocytic matricoma of the matrix. Here it was an EBUS. And here it was a pigmented squamous cell carcinoma. So 7 cases, you see, you say it is melanocytic, but only one of them was melanocytic nevus. And you don't need to go biopsy all of these patients. You can start with clipping, and clipping will exclude at least 5 or 6 out of these 7 patients. At least it will show that this is melanin. But here you will find the matricoma, here you will find the papilloma, here you will find the fungi, here you will find the onychomatricoma. So you can exclude cases by doing clipping, especially in these cases where you are not sure it is malignant. In some cases, if you are sure it is melanocytic and it has malignant signs, do the excision. But if you have a case where it is melanocytic, looks melanocytic, but you don't want to go for a biopsy because it doesn't have alarming signs, just do clipping and send for histopathology. Of course, differentiating hematoma from melanocytic pigmentation is very easy clinically first, but if it is difficult clinically with the staining, you can detect with diamine-benzene, the hemosiderin, and with Fontana, the melanin in the nails. And even if you have a patient with melanocytic lesion, you are not sure if it is benign and malignant, we are still far from using clipping to detect malignant lesions from benign lesions. But this is coming. And for example, this case was difficult to know if it is malignant or benign. It looks benign, but it is white, and there is a destruction of the nail plate. There is no Hutchinson. So some alarming signs, but not enough to do the excision. I did the excision and it was benign. But if I have done the clipping, it will just show melanin. This will not exclude malignant lesions. But in some cases, it might detect malignant lesions. For example, this case with Adam Robin and colleagues, or no, this was Dong-Gyun Lee. They suspected that it could be onychomycosis, pigmented onychomycosis, or melanocytic. And they just start with clipping. But when they did clipping, they found cellular remnants. And it is not normal to find cellular remnants of melanocytes at the distal end of the nail. You can't find them close to the matrix. But at the distal end of the nail, normally you find melanin, but you don't find cellular remnants of melanocytes. So when they found the cellular remnants, they excluded and they did the excision, and they found that it was sublingual melanoma. Another case by Adam Robin and his colleagues, and This was not pigmented. It was erythronekia, so they thought about glomus tumor or some matrix lesions. So they said we will start with clipping before going for biopsy or excision. When they did clipping, they found also cellular remnants of melanocytes. So cellular remnants in the distal end of the nail, this is not normal, and melanocytes. So they thought it would be melanocytic lesion. They did the excision, and it was a melanotic melanoma. So from the nail clipping, they made the diagnosis of melanoma. So use the nail clipping. The difficulty of nail clipping is that you have to have an excellent histopathologist to detect all these signs. Not any histopathologist can have this eye. Another case, not melanocytic, but they have erythronekia. They did clipping. You can see here the keratosis, subungual keratosis under the nail. And even in the clipping, you find the thinning of the nail plate and the subungual keratosis. So the diagnosis was onychopapilloma. It was clear from the clinical picture. But when they analyzed the clipping of the nail and the keratosis at the distal end, they found atypical onychocytes, no cellular remnants of melanocytes, but atypical onychocytes. So atypical epithelial cells in the nail plate and the subungular keratosis. So they thought it could be malignant, and they did the excision, and it was malignant onychopapilloma. And we know now that malignant onychopapilloma exists. This is new and only rare cases. It is very rare, but it happens. And this case was detected from the nail clipping. And you can see in the histopathology with the stain Ki67 that there is a clear sharp cut between the malignancy and the benign epithelium in the matrix. So nail clipping nowadays is helpful for onychomycosis, maybe gold standard for onychomycosis, helpful for psoriasis, helpful for sometimes melanoma, onychomatricoma always, onychopapilloma sometimes benign or malignant cases. So we can start to use it, but I think the future is coming for nail clipping because more and more specialists started already to analyze nail clipping in the different pathologies. So I think it is coming, and it is a good point of study if you are interested. Some more non-dermatologic uses. In this study, they analyzed the glycated proteins in the nails. You know, if the glycemia is high in the blood, it could be more in the nails, and especially the furosemide. And they found, they brought the patients, they cut their nails, all the patients who did hemoglobin A1C in the last 3 months, and they compared the level of furosemide, the glycated protein, with the level of hemoglobin A1C done in the last 3 months. And they found that they are comparable. They are comparable. When the hemoglobin A1C is higher, the glycated proteins in the nails are higher. So in many patients, they were able to detect high glycemic level in the blood during the past 6 months. And it is more representative than hemoglobin A1C because hemoglobin A1C shows you the level during the past 3 months. But with nail clipping, you detect the past 6 months of glycemic level. So we are still in the beginning, but this is very promising for diabetic patients. Instead of doing blood tests, you can do nail clipping to detect how was it during the past 6 months. Also in thyroid, they were able to show it is easy in the clinic, but it is very complicated in the lab. They have to liquefy it and then they do mass spectrometry to detect the levels. It is very complicated, but I think it is coming. Thyroid, they were also able to analyze the level during the past 3 months. Cortisol and testosterone, you see all the steps it takes to reach the results. It takes time, it takes a cost, but they were able to analyze cortisol and testosterone also from the nail clipping. So coming also for endocrinology, you can detect the medications also, antifungals or others. You can know if the patient is compliant or not. Arsenic poisoning, this is already known. You can detect the chronic poisoning with arsenic. And you can detect drugs and nicotine and alcohol. You can know if patient is smoker or he's alcohol addict from the nail clipping. We just analyze, and all these alcohol, nicotine, cannabis, opioids, cocaine, and amphetamines. They were detected in the nail plate. So they were detected in the nail clipping, and several studies are there, and they show the exposure during the past 2 to 5 months. So this could be helpful also for recruiting and, in these situations or marriage, in these situations where you analyze blood or urine, it is not representative for the chronic use, but nail clipping can detect the chronic use of these drugs. This is the last slide, and this is very interesting study. I love this study because they analyzed the nail plate of newborns to detect the drugs used by their mothers. So they categorized the newborns into two categories. Group one, newborns who were abandoned by their mothers. So non-stable families, more rates of drug addiction in these families. And the other group, regular newborns. And they found that in the regular newborns, stable families, non-drug addicts, very rare or even 0% use of these drugs. While in the abandoned newborns, they were at a quarter for many of these substances, which means that the mother was drug addict and they detected it from the newborn. And more than that, in the regular group, they asked the mother, were you drinking coffee a lot? And were you smoking during pregnancy? And then they analyzed the nails of the newborns. And you can find that they found the caffeine in the nails with the mother who said yes, and they found nicotine in the nails when the mother said yes. So they detected caffeine, nicotine, and all kinds of drugs from the newborn nails. And this is very interesting and very promising, not in dermatology, but in general medicine. With this, I finish, and of course, I invite you all to support the bit of Riyadh. And before that, I invite you to visit Riyadh to see the development in Riyadh, and that will show you that Riyadh will be interesting to host the WCD. Whether you are interested in the cities, cities are booming and developing very fast. Even if you visited Saudi Arabia in the past, if you visit now, you will find a quick change in the cities. And even if you are interested in the nature, Saudi Arabia is very variable geographically. If you like the deserts, the mountains, you will love it. And many spots there are now famous. And if you like the green mountains in the south of Saudi Arabia, this is also very interesting. Different climate, different paysage, we say, different geography, and you will enjoy it cold during all the year. If you like the crystal clear beaches, it is just to say that you will enjoy Saudi Arabia. Saudi Arabia is very variable, and that's why we won the Expo hosting and the World Cup hosting, and we'll see the development in the city very fast. We welcome you all, and with a strong belief in the leadership of Saudi Arabia in the Golden Continent, in Africa, and the strong collaboration, strong relationships between Saudi Arabia and the different African countries. I believe that if we win the WCD in Riyadh, that all African societies will be key players and will be big parts from the organization and the scientific content of the WCD Riyadh. So see you 2031 in Riyadh, all of you. Thank you so much.
Thank you very much, Dr. Azzam. Dr. Najib, go ahead, please.
Okay, thank you, Azzam, for this wonderful talk. And for sure that nail clipping is much easier than nail biopsy. And especially in onychomycosis. But for onychomycosis, we can use it for the superficial forms. The superficial and the form which name is the endonyx one. It is really interesting, and as I told you, that nail clipping is much easier than to do make a biopsy. Okay, any question from the colleague about the summit between Saudi and Africa?
Hello.
Yes.
Hello. Can you
Yes.
hear me?
Yes,
Yes,
Muhammad.
I'd like to know how the African country can help Saudi Society of Dermatology to hold the World Congress of Dermatology. What you are attending about us to do, just to know. Thank you.
Maybe Ru'a?
So I think, Dr. Muhammad, today is the first seed really of this scientific collaboration. And we probably need to do another meeting to discuss this collaboration and how we can advance this further. Today we have a tight schedule with many presentations. We have attendees exceeding 56 now. Looking forward for this information that we're sharing. But thank you very much for your question, Dr. Muhammad. And Dr. Najib, let's plan a meeting together to discuss this further.
Okay. Okay. I think the first meeting will be in Addis Ababa in April with Shimilis. Maybe if you are going there, we can organize something.
Sure, let's get in touch after this summit
Okay.
and talk all about it.
Okay, now let's move to the next speaker, which is Dr. Alice Amani from Rwanda. I visited Rwanda 30 years ago. So Alice is the president of the Society of Dermato in Rwanda, and she is in charge of training students and residents in the main hospital in Kigali. She will be talking about pediatric dermatology. Please, Amani. Please, Alice, sorry.
Thank you very much, Dr. Dos, for the invitation and the kind introduction.
Yes.
Would you see my screen?
Yes.
Okay. So I'm pleased to share with you some cases of pediatric dermatopathology. There are no conflict of interest to declare. First of all, we are sharing an infant of 27 days who presented to us with generalized body discoloration. It was having hyper and hypopigmentation all over the trunk, the head, and the limbs, with verrucous plaque on the feet, as well as vesicles on the dorsal hand. We took a biopsy, and from the blistering part, we can see that the patient was having intraepidermal vesicle 2 and some spongiosis. Looking higher magnification, we could see clear vesicles in the intraepidermis, full with exocytosis of eosinophils in the whole epidermis. And higher again, we can visualize multiple vesicles in the epidermis, intravesicular bars as well as in epidermis. The inflammation was also covering the dermopapilla with perivascular vesicles and some lymphocyte. With that, we came up with a differential diagnosis of incontinentia pigmenti. After 7 months of follow-up, the patient developed new ophthalmological complaint, of which cataract and strabism were noticed by ophthalmologists, but the other part of the body were intact, the neurological intact, the feet, every part was fit for that time. By 7 months, all the hyperpigmentation had cleared. He was just remaining with verrucous plaque on the feet. You can visualize that on the back. There were few scattered hyperpigmentation, very few. Almost all of them have cleared. A second case was a 4-month-old female patient who also consulted for generalized hyperpigmented net-like lesions all over the trunk all over the abdomen. We could see linear patterned verrucous plaque on the left hand as well as on the dorsal hand, of which the reticulated hyperpigmentation were distributed on the lower limbs as well as verrucous plaque. By then, we had a history that during birth, the child had also vesicles, but by the time of seeing, the patient was no longer having them. A follow-up of 1 year, the child developed as well ophthalmologic issues with leukochonychia, of which a pathology was done and confirmed with syndrome. This was done by a pathologist, and the retina was excised and operated. He benefit for ophthalmologic surgery, and now at least the one eye is doing very well. And for the skin, it has also cleared. So lesson learned is that incontinentia pigmenti need to be multidisciplinary management involving ophthalmologists, neurologists, surgeon, ophthalmologist, dentist. All of them need to follow up this patient. As we noticed that our first 7 month and 1 year visit, already our patient were presenting ophthalmologic presentation. So we reassured the family on the skin since it was again improving well, and also recommended other specialists follow up. Incontinentia pigmenti is a mutation, is a X-linked mutation, whereby you have natural factor kappa B mutating, leading to cell death or apoptosis. Reason why our first patient presented with blisters, and commonly it is clear that the first year of life, patient will present with blisters. Later on, it can have the concomitant lesions, but surprisingly in our patient, one of them had 3 stages at once, just after within the first 27 days, and we recommend also a pediatrician visit, whereby patient can present with seizures, can present also some protein linkage. So the stages of incontinentia pigmenti are 4 usually, and classically the stage 1 will be the one presenting with vesicular bullous, the second stage with verrucous stage, and the third hyperpigmentation, the fourth being atrophy or hyperpigmentation. We shared these 2 cases because they were of interest, as each of them presented more than 2 stages at once during the first 6 months, and for one, the first 4 weeks of life. CNS can be affected and present with seizures in the first weeks of life, and in 30%, these seizures can be seen. The eyes are affected in 20 to 25%, teeth in 80%. So far, I update that our patients do not have teeth issue, so they are among the rare who did not present the teeth issues. Hairs can be affected with in 50% of cases, and nails can be affected. So this means or ectoderm arising organ can be affected, and this implies that we should involve all the specialists to help the management of this patient. So far, what we learned from these 2 girls is that if you start the screening of every specialty, you have the chances to detect manifestation of each of the organ and act on timely, wisely, and improve the well-being of the patient. As our 2 patients presented incontinentia pigmenti with eye involvement, they were well managed. Of course, the skin is not yet repigmented in a good way, but the other organ and other specialists are following up our patients. Our third case is a patient also with xeroderma pigmentosum. We easily see that he had ulcerated tumor lesion on her forehead, as well as on the tip of the nose, as well as cheilitis on the lip. So we took an excision biopsy from the lesion from the forehead, which was a basaloid tumor characterized by clefting and basaloid. With this, we were quite sure that this is basal cell carcinoma, one of the commonest tumor we found in people affected with xeroderma pigmentosum, and needs diagnosis and, of course, surgical management in timely manner. Of course, sun protective factor, counseling. The good thing for this patient, so far, no more tumor, but he cannot attend the school as the eyes also were affected. So now followed with ophthalmologists to see if they can provide the support to keep ongoing life as anyone else. Our fourth case, it was a 3 days old female patient who presented with multiple ulceration just at birth. We can see ulceration. She also had some vesicles, but unfortunately, this one, I don't know if you can see it, a vesicle and multiple ulceration. When we took the biopsy from this infant, as you know, most of physicians would think, okay, maybe this is some were putting down the congenital syphilis, yet the mother was negative. There were so many impressions, and of course, the family was also very much affected as they couldn't know what was the disease. So histopathologically, we also can share this slide, which is of not good quality. I'm sorry for that. It has also intraepidermal vesicle. We can see easily that the subepidermis was not affected. So we classified this under epidermolysis bullosa simplex, but tending to be junctionalis because we didn't have the chance to do a genetic. It is pending. We requested, but not yet done so that you can confirm. So what we did for this infant, we did the wound care, also advised the mom that this condition is a lifelong disease. So they need a closer support. They need less abrasion, less trauma, because any trauma can induce a new blister. Our other case was a boy, again, a 10-year-old boy who presented with multiple vesicles and some bulla, mainly crust, some were healing, and the mucous membrane were also affected, like oral cavities. Also on the penis, we can see the crusting and healing of the wound. We took the biopsy. Fortunately, the patient was having a suprabasal cleft, as we can visualize here. This is a suprabasal cleft. We know that the age of 10 is not the age of pemphigus vulgaris. Commonly should be late in life, but this was another characteristic pemphigus vulgaris in a child of 10 years, whose diagnosis was made properly and managed, and now he is just well and had improved. I do recognize the team I work with. These are the team of my resident who contributed to provide good pictures and who are actively involved in our dermatological care and under training. I do thank them and also thank the other colleague who participates in the dermatology build-up in Rwanda as well as internationally. These are where my references. I thank you very much for the time. I thank you very much for invitation and welcome questions.
Thank you very much. It's really an eye-opening for different manifestation of different diseases in pediatric patients. We really thank you for sharing this expertise. Due to lack of time, I would ask our attendees if they want to type their questions or email it later on. We still have 4 more speakers and 1 hour to go. Thank you very much, Dr. Alice. So our next speaker, Dr. Mohamed Masire Souma, and he is a Guinean brilliant dermatologist, professor specializing in immune-compromised dermatology and Kaposi sarcoma. He is an academic at Jamal Abdel Nasser University and leads the Kaposi sarcoma unit at Donka University Hospital. He received advanced training from institutions in Thailand and France, and he will be talking to us about acne on pigmented skin, clinical particularities, and therapeutic approach. We look forward for your talk, Dr. Mohamed.
Good morning, and I would like to thank the Saudi Society of Dermatology for this meeting, and I am very happy to be with you. As you know, my talk will be about acne on pigmented skin, clinical particularities, and the therapeutic approach. Okay, so I will talk. First of all, we will do the introduction, and we will talk of the epidemiological overview, risk factor, clinical presentation, and therapeutic approach, and we will finish with the conclusion. So, as you know, acne is a chronic inflammatory disease of pilosebaceous unit. It is a common reason for dermatologic consultation our uh, in our condition. So acne is have an important impact on quality of life in our condition. So how about the epidemiological situation? As you know, acne is a common of disease in skin condition. So it's the eighth place in overall disease prevalence globally. And around the world, about 85% of people aged from 12 to 25 are affected. And it's estimated that there are 117 million incidence case of acne vulgaris. And this study showed that from 1919 to 2019, the increase of acne cases. And this slide show the incidence of acne in several countries around the world. As you know, the prevalence is varied country to country. If we look at the sub-Saharan African country, this slide shows that the prevalence is high in this country, in this part of the Africa. So this study from around 20 countries who include about 50,000 of patients, and the population affected is age from 7, and the prevalence of acne was 18, around 90%. And in sub-Saharan Africa, the prevalence of acne varied country to country, and several studies show that the prevalence is varied from 15 to 80%. And this slide shows the age and the sex. As you see, the female is more affected than male. And how about the risk factor? And we know that in acne, several risk factor is identified as a genetic factor, hormonal factor, emotional stress, tobacco consumption, sun exposure, atmospheric pollution. And in our context, the skin bleaching is more associated with acne. So that we are trying to sensibilize the population from this practice. And the medication and the diet, even if the controversy is about this diet. And now we will see some clinical cases to talk about the clinical particularities of acne in pigmented skin. So we know that the lesion of acne can go from invisible lesion to scarring lesion, and from the sebaceous gland, and with participation of some infectious agent and comedogenic agents, we see the microcomedon lesion and the non-inflammatory lesion, the inflammatory lesion, and the healing lesion. So in all form of acne, this theoretical kinetic of acne lesion is observed. And the primitive elementary lesion, or we have three types of lesion: the hyperseborrheic, retentional lesion, and inflammatory lesion. And if we look at of the retentional lesion, we can see the comedon, open lesion, closed lesion, and microcyst. In inflammatory lesion, we have a papule, pustule, nodule, and cyst. So this is the common site of lesion. And as you know, the face, the shoulder, the chest, and the back can be affected. And this is the retentional lesion. As you see, we can observe several comedon open and closed comedon, some papule, and in the all form of acne in pigmented skin, you will see the hyperpigmentation. This is a more frequent particularity we can observe in acne on pigmented skin. Here too, we can see a multiple retentional lesion with hyperpigmentation. Here too, we can observe the multiple retentional lesion with some papule and the rare pustule. Now, in this study, from two studies in Africa, we can see that the retentional lesion is more frequent in our condition. Here, this study from Cameroon and this study from Senegal, we can see that the retentional form is more frequent. And the second form that we can observe in pigmented skin is inflammatory acne. In pigmented skin, we can see several pustules, the nodulocystic lesion, and as I told you, we can see to the hyperpigmentation. And this hyperpigmentation, as we told before, is observed in all forms of acne. And here, some patients, before coming to hospital, can do several treatments that can aggravate the condition. And here too, the inflammatory acne, that you see some bleeding lesion because of the manipulation of lesion by the patient. And here too, you can see hyperpigmentation and the crust lesion. This is the nodulocystic acne, as you see, is the severe form of acne, and we can observe multiple nodulocystic lesion that can sometimes the treatment of this condition is very difficult in our situation. So we can observe too the scarring lesion. And the post-inflammatory hyperpigmentation lesion is more likely to occur in pigmented skin. That is the challenge when we have a patient with acne condition. So the treatment can integrate it the challenge to have less hyperpigmentation of in patient after the treatment. So here you can see the hyperpigmentation with post-inflammatory hyperpigmentation with sometimes the escoriation lesion. Here we can see the scarring lesion, and this is the atrophic scar. This is to the clinical particularities we can observe in pigmented skin. Here we have a hypertrophic scar that is to observe on pigmented skin. So this study from Togo so that hyperpigmentation is observed in about 83% of patients in their condition. So we have two escoriation. So hyperpigmentation, escoriation is the particularities we can observe in pigmented skin. Here we can see the escoriation lesion, and so where escoriation can occur that because of a patient can manipulate the lesion, or they can apply some topic that is not recommended on acne condition. Here, so the skin bleaching is frequent in sub-Saharan Africa. So in the patient that practice this situation can develop acne. So when we receive this patient, sometimes it's difficult to do the treatment because of the skin, the bleaching agent can contain the steroid agent. So this study from Benin and from Togo and Cameroon, we can see the clinical form of acne that is observed on pigmented skin. Here too, the clinical form occur on acne. This is a study from Benin. As you see, we have several forms from retentional acne, inflammatory acne, cosmetical acne. That is the acne can occur on patients that who practice the skin bleaching. So the severity of acne can be assessed with the GAA, a Global Acne Severity Scale. In our condition, this tool can be used to assess the severity of acne. So, how about the therapeutic approach? Recently, the SODAF, the African Society of Dermatology, a French-speaker countries, do the work to do the algorithm when we have a acne condition, how to can treat it. So I will share with you this algorithm to take care of acne condition on pigmented skin. So when we have a very mild acne condition, we can prescribe dermocosmetic alone with the following action. So the dermocosmetic should have keratolytic properties, sebo-regulating, skin barrier protector, and microbiome moisturizing, photoprotective, and we can do it. we have to apply it 1 to 3 times a day to the affected area, and we have to give the advice and see the patient again for follow-up at day 15 or 20, 21 to assess the tolerance and the compliance. Then once a month to assess the progress up to 3 months. So when we have a mild acne, so we can prescribe a benzoyl peroxide or topical retinoid and the topical antibiotic to apply to the lesion in the Monday for 3 months. We can combine two with the dermocosmetic and give the advice we can follow up the patient. So for the moderate acne, benzoyl peroxide or topical retinoid or azelaic acid can be prescribed, and we can combine with dermocosmetic, give the advice, and see the patient for follow-up. For the several forms of acne, usually it's recommended in this algorithm to combine a benzoyl peroxide, topical retinoid, alternatively in the day at the night for 3 months. We can combine with dermocosmetic agent and give the advice and see the patient again for follow-up. When we have a very severe acne condition, usually in this algorithm developed by SODAF, it recommended to prescribe isotretinoid orally. And we can associate with dermocosmetic, and the patient have to be followed. So for acne who can occur to skin bleaching, first of all, we have to assess the stage of acne, give advice on voluntary skin depigmentation, and advise the patient to stopping it, and give him an alternative moisturizing agent, and propose and carry out weaning with the informed consent and the consent of the patient, apply the treatment adapted to the stage of the acne as we talked before. So in conclusion, we know acne is major health problem on pigmented skin because of the complication who can occur in this condition. It have a psychoaffective repercussion that is observed in several cases. Even if acne occur on teenager or the adult, this condition can occur. The treatment is long and difficult in our condition because even if we do the treatment, the hyperpigmentation, the post-inflammatory hyperpigmentation can occur. So another problem that we have is the accessibility of the treatment, because some treatment is the cost of some drug is very high that the patient can have not a possibility to have it. So I will end my talk here and to thank you for this invitation, and thank you very much.
Thank you very much, Muhammad, for this talk. You are so lucky because your patient come at D15 and D21. Our patient in Tunis, they don't come for that. You are so lucky for that. Yeah,
it's the algorithm that we propose for the practitioner and the physician. Then they receive the patient, if possible, to talk him to come and to access the tolerability of the treatment.
Thank you.
So you are right. It's not evident that the patient will come.
Thank you very
Thank you
much,
very
Muhammad. Now the next speaker is Mariam Kebe, who is professor of dermatology in Nouakchott, and we consider her as a Tunisian citizen as she was awarded PhD in medicine in Tunisia. She is a very active person in the field of dermatology and teaching. She is national coordinator of the National Program for the Management of Skin Disease. Mariam, please, no more than 15 minutes.
Good morning. Good morning, everybody. Thank you, my dear friend. Thank you to everybody for this invitation. I'm going to share my screen. Sorry. I'm very happy to be with you today for this webinar, Saudi Africa webinar. I'm going to share with you the daily dermatology in Mauritania. As said Professor Dos, I'm also Secretary General of the Mauritanian Society of Dermatology. In our condition, sorry. In our condition, skin disease constitute a serious health problem in Mauritania. These diseases may include fungal, bacterial, scabies, acne, skin bleaching, and neglected tropical diseases like leishmania, leprosy, mycetoma, etc., etc. NTDs are characterized by their co-endemicity, leading to disability, stigma, discrimination, impaired quality of life, and negative impact on the socioeconomic level. Mauritania is a northwest African country. You can see here, for a population less than 5 million inhabitants, for an area more than 1 million kilometers square. Our neighboring countries are Morocco, Senegal, Algeria, and Mali. What are the contexts of skin disease management in Mauritania? They represent approximately 5% of all diseases. There is also a low number and unequal distribution of dermatologists. We are today 22 dermatologists in Mauritania. 20 of them practice in the capital, Nouakchott. There is also the high frequency of common diseases that can be treated at the front line of health structure. And there is also, unfortunately, an imperfect knowledge of most of these diseases by the frontline health personnel. That will give us a delay in diagnosis, an abnormally high cost of the treatment offered, and an excessive use of higher level services. In Mauritania, for the management of dermatosis, we have the dermatology department of the National Hospital with outpatient and hospitalization. There are also 3 other hospitals with dermatology care outpatient. There is recently, and thank you to Professor Dos, a Mauritanian Foundation for the fight against skin disease, where is outpatient. At the level of Ministry of Health, there are 3 programs who are working together. There is a national program for management of dermatosis. I am the coordinator. There is also a national program for the control and leprosy, and a national program for neglected tropical diseases. And all these programs work together for the management of skin diseases. Here we are going to share some studies carried out in Mauritania, as well as registers and rural medical consultation and the dermatology project. We will analyze also the database of the health information system of the Ministry of Health, focusing especially on the skin neglected tropical diseases like scabies, fungal, leishmania, mycetoma, and leprosy. and we will share with you our iconography of our dermatosis. In this slide, you can see two tables. The first one is about typology of dermatosis. It was a real consultation made by 3 dermatologists for 213 patients. And as you can see here, the top 10 of dermatologists seen by these 3 dermatologists was first one, fungal infection in 30%, followed by scabies, 80.8, followed by eczema, 16.5, acne, skin bleaching, impetigo, urticaria, melasma, palmoplantar keratosis, and there was also many other skin diseases. The second table you can see here, it is a diagnosis profile for our project of teledermatology. This project is about to care dermatology in rural regions. Here also this diagnostic was made by GPs and nurses in those regions where there is no dermatologist. As you see, they are both similar. Here we have mycosis first also, 31%, followed by bacterial infection, eczema, scabies, chickenpox, acne, larva migrant, skin bleaching, urticaria, and other diagnoses. Here we have the national database during 4 years, 2020 to 24, sorry, and entities represent 15% of all skin diseases. As you see here, scabies were represented in 10%, mycosis 4%, leishmania, leprosy, mycetoma, and other skin diseases. Here you can see this child with scabies, this one with fungal, a large mycetoma on the back here, leishmaniasis, and leprosy. To summarize, in total, according to the dermatologist consultation registers, teledermatology and national information, the top 10 of dermatosis in Mauritania are fungal, like dermatophysitis, candidiasis, and mycetoma, who is the most represented mycetoma in Mauritania, eczema, atopic dermatitis, and contact eczema, bacterial infection like impetigo, erysipelas, actinomycetoma, who is rare in Mauritania, and leprosy, but these are very debilitating skin diseases. Parasitic infections, scabies are very common, larva migrant, leishmaniasis, acne also, skin bleaching complication, viral infection like warts, molluscum contagiosum, chickenpox, herpes zoster, and others. Melasma is very common, urticaria, and systemic lupus. Mycosis are very common. They are our first reason of consultation. Here on the national database, we have more than 12,000 of mycosis. Here we have this child with mycosis. You see, here we have also mycosis on dermatophysis on the head, pityriasis versicolor, and candidiasis on this hand. Fungal infection here or on hand with onychomycosis, facial fungus, and here fungus for the beard and the neck. Skin bleaching is very common in our condition. Here we have diffuse fungal infection of a large body surface related to the use of topical corticosteroid for skin bleaching. Scabies is very common too, as you see on our first slide. Here we have profuse super-infected scabies. Sometimes the scabies is associated with skin bleaching, as you see on this patient. Eczema is our second reason of consultation. We have very much of atopic dermatitis, like you can see here, with oozing lesions on this child, and contact dermatitis is very common too. Here we have also atopic dermatitis with oozing lesion, diffuse skin dryness, here, as you see on all patients. Impetigo bacterial infection is our third reason of consultation. We have crossly purulent lesions, and there are around the orifice
Mariam,
on this space, as you see here. Yes, please.
we don't have enough time for the other.
Sorry, I'm going quickly. Here we have erysipelas frequently associated with skin bleaching. Acne is very common. Skin bleaching also with large superinfected mycosis lesions, leishmania, leprosy, as you can see, mycetoma. Other skin diseases like larva migrant, molluscum contagiosum, herpes zoster, psoriasis. I would like to talk about albinism. We have about 200 patients in Mauritania. Here you see 3 patients with squamous cell carcinoma. Xeroderma pigmentosum is rare but very debilitating disease. Here we have 2 children from the same sibling. The boy is died at the age of 8, and the girl now aged 13, and she underwent surgery for multiple diseases. What are the difficulties in our care, in our condition? I told you that we have lack of training frontline workers in dermatology. That's why we set up a dermatology project, who is now working with 26 associated health centers. Poverty of population, disability, lack of equipment, and certain medication. Our perspective, we are going to manage dermatosis in renal condition by teledermatology, albinism thematic consultation, awareness raising and photoprotection, skin bleaching awareness, NTDs management, and support young dermatologists continuing training. In conclusion, skin disease are a public health problem in our country. It represents 5% of all diseases. We do have innovating approach to have to be adopted by endemic countries to achieve results, like teledermatology, foundation of dermatology, renal consultation, and an integrated approach for case detection, continuing professional training at the front line of care, health education, availability of medicaments, and community engagement will achieve results that can help skin care management. I'm going to thank all Mauritanian dermatologists for their commitment, and I'm looking forward to see you in Mauritania. If you want to have very good seafood, you have to come in Mauritania. Thank you.
Thank you
Thank
very
you.
much,
Yes.
Dr. Mariam. It's really a lot of challenges that you're facing, and you're doing amazing work. We're also happy to collaborate and further, because we do have also a national program now for xeroderma pigmentosa with increasing awareness and photoprotection. So we also can do something collaborative in terms of awareness campaigns. So probably in our next meeting, we can discuss all these collaborative options that we can do, scientific and awareness to the public. Thank you very much.
Yes.
Our
Thank you.
next speaker is Dr. Margaret Oliver, and she is a very aspiring dermatologist who had extensive training in different countries, including the United States, Russia, South Africa. She also holds a lot of membership of societies, but what really catched my eye is the founding president of Dermatology Society of Namibia. And also, she is part of the African Women Dermatology Society. So, Doctor, we look forward for your talk.
Thank you so much. Let me just share my screen quickly. All right. Yep, it was working. Now it's not working. Here we go. It's not the other way. So good morning, everyone. Ladies, gentlemen, and colleagues. My name is Margaret. Yes, I'm from Windhoek in Namibia. I'd first like to start by saying thank you so much for the organizing committee, particularly Prof. Dos for this opportunity and for creating this platform and involving us to collaborate and grow and advance dermatology within Africa and with the Saudi society as well. It's really an honor and a privilege to be part of this. I think many people don't really know much about Namibia, so I just want to give you a quick overview of what's happening in Namibia. So this is Namibia. It lies in the southwest of Africa with the Atlantic Ocean to the west, Angola to the north, Botswana to the east, and we are north of South Africa. We became a sovereign state in about 35 years ago after gaining independence from South Africa. So Namibia is a relatively young democracy and still very much in our infancy stages of development. We're a very large country with a small population of about 3 million people, making Namibia the third least densely populated country in the world. We also have about 10 dermatologists, which means we have about 1 dermatologist per 300,000 people. Namibia's healthcare system is two-tier, where we have 80% that is dependent on the public sector and about 20% of the population that has access to private healthcare. There's also a paucity of specialized medical skills in Namibia, and this will be highlighted in this case that I will present today. Because patients are forced to travel vast distances to access care. Most of these services are usually localized in the capital in Windhoek, where I am from, as well as one of the major cities in the north of Namibia, where the vast majority of the Namibian population lives. And this is also where our index patient is from. So that is called Oshakatyo Ondangwa, which we will be referring to later. So this is a 39-year-old female that presented to our clinic in the beginning of 2022. She was referred from the northern parts of the country, not from the main referral hospital. She was wheelchair-bound with amputation of the left leg and arm. She was alone and not accompanied by any family members, only by the nursing staff. She presented with complaints of a black swollen right leg, causing severe pain and discomfort. She gave the following history. In 2015, a snake had bitten her on the left arm. This then led to gangrene and the eventual amputation of said left arm. In a separate snake bite incident in 2017, this time on the left leg, an amputation had to be performed again due to the onset of gangrene. Then in 2019, the right leg started swelling up and turned black. This time, however, there was no report of a snake bite. Of note, she is known with schizoaffective disorder and currently on fluoxetine and risperidone. On closer investigation of the right lower limb, we could appreciate edema with this dark soot-like hyperpigmentation. This was removed with water-soaked and cotton wool. The leg was warm to touch and all pulses were palpable. While cleaning the leg, the patient started crying and this was the mistake that I made. I confronted her directly. She denied the application of any black substance to the leg. But it was evident that we could remove this substance, that it was an exogenous pigment, because the underlying skin underneath was essentially normal and the consistency of the skin was unchanged. There was no hyperpigmentation or the soot on the hard to reach areas like the popliteal fossa or the posterior aspects of both the thighs. We could also appreciate that there was transfer of this black soot onto the white wall of the examination room. What was interesting is that we could also see this ligature marks on both of the legs, both the one that was previously amputated in 2017, as well as the current edematous leg. And then we found this cord in her clothes, and that was wrapped around her right leg. Apart from the crying, there was really no, the rest of the general examination was unremarkable, and the rest of the integument was intact. We then went on to trace all of the previous investigation that was done on the National Laboratory Database. And we found that over 40 blood tests had been done in the last 6 years in different health facilities across the country. Most of these blood tests were within normal limits. The autoimmune screen was also negative, clotting profiles were normal, and there were no signs of inflammation. We also managed to trace the skin biopsies from the current leg that was very hyperpigmented, and none of them showed any evidence of necrosis or gangrene, inflammation, or infective process. All that it basically showed was a little bit of spongiosis in the epidermis. This then drew into question the validity of the previous claims of gangrene that had led to the amputation of two of her major limbs, both the left arm and the left leg. We managed to trace the histology of the below-knee amputation from 2017, and macroscopic findings showed muscles that were grossly healthy, with only a small scar on the dorsal foot. Even the skin was normal, apart from that mild focal spongiosis in the epidermis. There were no other pathological features seen. There was no evidence of gangrene or necrosis. An extensive CT angiogram was also done in 2021, and they found a patterned normal-sized aorta with normal common external and internal iliac arteries. There were features of multiple varicose veins in the right leg and thigh. So take into consideration all of this, the history, the clinical presentation, that essentially the patient was well. We came up with a diagnosis of dermatitis artifactive, also known as, or the factitious lymphodematous type. Right, so I'm not going to go too much in the interest of saving time. We all know what dermatitis artifacta is. It is a term that is basically applied to patients that self-inflict skin lesions to satisfy a psychological need in which they are usually not consciously aware. So they don't know that they're really doing it. It's a form of stress relief. If asked, these patients often deny any involvement. So given the lack of honesty, the lack of cooperation, and the lack of disclosure, this disorder is sometimes difficult to diagnose. There is a great female predominance in the prevalence. You can get a great variety of clinical presentations depending on the patient's creativity and the methods used. Excoriations, ulcers, paniculitis, localized crusting, eczematous lesions, purpura, bruises, and edemas, all the primary lesions, all the secondary changes. Ulcers and excoriations are usually the most common presentation of DA. A useful clue to the diagnosis normally is that the lesions are quite bizarre, angulated shapes of lesions. These lesions usually localized on the non-dominant limb, like in our patient, where the left arm and the left leg was the first ones to be amputated. And they usually give a very hollow history, like what are the chances of being bitten by a snake twice? And here, just an example of a couple of clinical variations of dermatitis artifacta. Right, so I want to take a look at the factitious lymphedema, which was first described in 1911 by Secretan, and therefore it's known as Secretan's syndrome. Smith and Al defined a criteria for if you suspect a lymphedema that is factitious. Usually it's a recurrent unilateral lymphedema without any apparent lymphatic or venous obstruction is number one. And number two, if you can see transverse stria or sulci proximal to the edema. The criteria was elicited in our index patient. Right, several other types of edema caused by ligatures have been reported in the literature, including edema of the nipple, the tongue, the neck, and even the scrotum that leads to self-castration. An honorable mention in terms of a differential diagnosis for our index patient was something called body integrity identity disorder. This is a very rare and quite a secretive condition in which there is a mismatch between the mental body image and the physical one. These patients have an intense desire to amputate a major limb or sever the spinal cord in order to become paralyzed. Amputation of the healthy body part appears to result in remission with BIID. But in our patient, she did want an amputation. She had two of them, but still it didn't satisfy her urge, or it didn't lead to a remission. So treatment is quite challenging for any dermatitis artifacta. And there's some controversy as to whether or not the patient should be confronted when recognizing that this is a dermatitis artifacta. However, given the nature of this disorder, it is more fruitful to provide a supportive environment early in the doctor-patient relationship. And this is what I did wrong with our patient. I confronted her head on. I cleaned off the soot, I was like, but mom, what are you applying to your leg? Where's this coming from? It was absolutely a wrong approach. And that's why I want to present this patient for future, learnings for everyone out there, that actually, you should have a supportive approach to the patient. Obviously, consultation with an experienced psychologist is prudent. So, core principles of engagement: be non-judgmental, don't blame or accuse, don't challenge this patient and say that this is self-inflicted. Support the patient, provide comfort, help with the wound care, and stabilize the symptoms. Provide continuity of care. So first build up that trust the patient has with you, and then you say things like, I can see that the lesion is causing discomfort. Let's work together on relief. Or you can say stress can have many effects on the skin. Let's explore how to treat this over time. Don't be accusatory. Support is what you need. So provide space for the patient to talk without pushing to the insight that this is actually caused by her mental state prematurely. So in closing, factitious lymphedema reminds us that not all swelling, erythema, or ulcerations is what it seems. The skin is a canvas for unspoken distress. Management is multidisciplinary, including medical care, psychological support, teamwork between derms, psychiatrists, psychologists, social workers. Create a circle of care. What's most important is the stance we take as clinicians. Confrontation rarely heals. Empathy, patience, and continuity of care often do. Our role is not to expose, but to support, not to judge, but to accompany. So we'll leave it here with this reminder. In DA, as in with much of dermatology, the most powerful treatment we offer may not be the prescription, but the relationship we build with the patient. Thank you so much for your attention. These are my references.
Thank you, Margaret. And
welcome.
Just 2 words to say. Спасибо and хорошо.
Отлично, молодец. Да, не за что.
Which means thank you very much and congratulations. And keep in touch, because I have many cases of facts dermatitis and pathomimicry and something like that. So keep in touch. We'll do something together.
Brilliant, Prof. Thank you so much.
Okay. So the next speaker now is Dr. Nadia Al-Faraidy from Saudi Arabia. She will be talking about multibiologic failure in psoriasis. Nadia?
Yes, Assalamu alaikum, everyone. So thank you. Can you hear me?
Yes, very clear, Nadia.
Okay. So first of all, thank you, Dr. Najib and Dr. Roa, for this wonderful opportunity to participate in this first Saudi African Summit. It's really both heartwarming and inspiring to see such remarkable efforts being made to serve and advance dermatology in our regions. And I really look forward to continuous collaboration. And for the speakers, really, thank you so much for those inspiring talks. I was certainly very energized and excited. So I'll begin sharing my screen. So is my screen clear?
Yes.
Okay. So I'll be talking about a topic that is becoming more popular in our region, which is multi-biologic failure in psoriasis. So as we know, biologics, they're the evolving landscape of psoriasis treatment, and they are continuously evolving. We have year after year, and maybe the residents are also very aware of this, that they have to keep remembering all these new emerging biologic therapies and also molecular therapies that are being offered for psoriasis patients. So just a quick reminder of where we started with psoriasis back in before even the 1920s and very long ago. The disease has been treated with topical treatments and much efforts, even, for example, the Gurkha regimen. And then in the 50s, it was realized that immunosuppressive medications can actually help with the skin disease. And really, if you are before the era of biologics and you remember treating patients with retinoids and phototherapy and witnessing the evolution of biologics, then definitely it's your time to go get a colonoscopy, as they say. So, of course, now the efforts in biologics are ongoing and evolving. And we know that psoriasis is a chronic immune-mediated inflammatory skin disease, and it is estimated that 125 million people worldwide have this significant, impactful disease. And it impacts your physical, emotional, and social well-beings, with biologics now transforming moderate to severe disease management. So, of course, you all remember probably how before the PASI 50 maybe was something really promising, and now we have even PASI 100 being the goal. However, this success has also revealed a new and complex clinical challenge, which is a subset of patients who do not respond to the most advanced treatments. So what is multi-biologic failure? Well, real-world data estimates that approximately 6% of our psoriasis patients will exhibit this form of refractory disease. But first, before we say this is failure, please revisit the diagnosis. Think of other papillosquamous mimickers that could look like psoriasis. I feel we're very indoctrinated now to think of every papillosquamous disease as psoriasis, given the efforts of education for psoriasis in and education about the biologics. But we have to remember that a simple tinea corporis could be looking like psoriasis, and you definitely have to make sure that you take a biopsy or rule out other diagnoses. It's also very useful to have this biopsy because, for example, we had a patient who wasn't responding to her psoriasis treatments, and then we reviewed her biopsy before she started the treatments, and it was clear psoriasis. However, her new biopsy showed clear picture of mycosis fungoides. So this first biopsy can actually also save you in the sense that you did think of the disease and you did not miss a diagnosis that was ongoing in the past. And of course, you repeat the biopsy if necessary and check the product storage and compliance. So make sure also that the patients are storing the medications well, and make sure that they are compliant to the treatment. For example, in the form of factitious dermatitis, for example, you can think of also Munchausen or Munchausen by proxy. For example, the patients, they want this validation and this seeking for attention, and they may not even start those medications or not use them properly in order to get gain. Sometimes the patients will also take the medication and not use it and perhaps give it to a loved one who cannot afford it. So you have to keep all these factors in mind before you really establish that it is treatment failure. So is there a true definition for multibiologic failure? There's not really a universal definition, but it's frequently defined as the failure of at least 3 biologics from 2 different mechanistic pathways. So from 2 different classes, for example. And more recently, it's even explaining that it is 4 or more biologic agents. But regardless of this precise number, patients with these criteria really require specialized therapeutic considerations to understand what treatments we can offer them. For example, this is one of our patients where we have to admit defeat until now, where started as a pustular psoriasis because he was suppressed suddenly by his cessation of immune therapy. And then he was okay on TNF-alpha inhibitors, however, eventually had to be switched to ustekinumab, then guselkumab, did not respond to the guselkumab, switched to ixekizumab, and now ixekizumab with methotrexate And still, unfortunately, he's not showing very good response. The other thing to consider is whether it is primary or secondary failure. So a study from Korea found that patients who required a switch to new biologic, usually secondary failure was the most common. So they do have response in the beginning, and then they lose this efficacy. Primary failure would be the initial therapeutic response would not be achieved. So the PASI 75 was never achieved within the first or after 16 weeks. Secondary failure is usually over time, you are seeing a loss of effectiveness. So what is the patient profile for multibiologic failure? Multibiologic failure patients often present with a more aggressive and long-standing disease. So you will have patients with earlier psoriasis onset. So in the history, you will see that those patients have been struggling with this disease for over 20 years. And then longer disease duration, so early onset and longer disease duration, and higher disease severity. So even when they have started, it would have been more extensive and thicker with a more aggressive PASI score. And then, of course, specific subtypes, such as erythrodermic psoriasis, which will take up more than 90% of the body, that can be a link to multibiologic failure as well. There are certain comorbidities also that can be associated. So with multibiologic failure, you will have a higher tendency to develop comorbidities. And so in this Italian study, you will see that psoriatic arthritis, for example, diabetes mellitus, and cardiovascular comorbidities were higher in these patients, which also then makes you have limited choices for their treatments. It was also seen that it's more in female sex, hyperlipidemia, and acne. So when we talk about acne, it also triggers that whole concept of neutrophils and whether really what we are experiencing is probably this swaying between the phenotypes, between plaque type psoriasis and pustular psoriasis. Perhaps these patients do have a genetic tendency to develop pustular psoriasis more than others, but because we are starting the biologics early, we are kind of dampening this phenotype and not really seeing it as true pustular psoriasis. So it does seem worthwhile to consider that perhaps we should do some genetic profiling for the patients who do have this psoriatic multibiologic failure to see whether they do have the tendency to develop pustular psoriasis, for example, in IL-36 or CARD14 or other genetics that are associated with pustular psoriasis. So what are the mechanisms of treatment failure? We know about immunogenicity, where the patients do develop anti-drug antibodies. However, also some studies show that it's not necessarily that when you develop anti-drug antibodies, you develop failure, but that is something to consider, especially in the earlier biologics, such as TNF-alpha inhibitors. The genetic predisposition, so it was seen that certain HLA types would have more tendency to have multibiologic failure, but also to consider is the tendency for pustular psoriasis, such as IL-1 and IL-36. Other comorbidities, which metabolic disease, for example, can trigger biologic failure, as well as the necessity to have some medications for other diseases where they cannot stop that medication, but it will continuously trigger psoriasis. The body mass index, so the higher the body mass index, perhaps this leads to an underdosing of these biologics. And then, of course, smoking and stress, which further triggers inflammation. So what are the clinical management strategies? Well, there are evidence-based approaches for this clinical challenge. We have a growing body of evidence from real-world, retrospective, and multi-center studies, which find sequencing, selection, and optimization for these patients. And so also to remember that a failure of one agent does not predict the failure of other agents, even within the same class. So you can do intra-class switching, so switching in the same class, or inter-class switching, so between the classes, keep in mind that the IL-17s will have a faster response, and the IL-23s have been associated with a longer drug survival rate. And beyond the switching, there's also other potential strategies. You can do dose adjustment. So, for example, there are studies about bimekizumab and guselkumab where they have increased the dose for every 4 weeks. And then combination therapies have also been explored so far. For example, we are taking references from our colleagues in rheumatology, where they would combine IL-17 inhibitors with JAK inhibitors, such as tofacitinib, but also with apremilast, for example. You can also add the TYK2 inhibitors to enhance the effectiveness and achieve better clearance. And you have to also consider lifestyle modification of the comorbidities and try to look for medications that you could perhaps switch that are triggering the psoriasis in these patients. And also for patients with metabolic syndrome, you can consider the GLP-1 treatments. And in research and advocacy, you will see that the U.S. National Psoriasis Foundation has a multi-biologic failure registry where they are collecting the patients and trying to profile them to see what factors can be associated with this treatment failure. And this, of course, brings together collaborative force between patients, physicians, and researchers to meet directly and with the legislators and their teams. And this will help also with lawmakers, so in insurance, and now with the privatization in many of the countries, you will see that it is important to explain to the insurance why those patients require these switching or even increase in dosing or additions of other expensive medications. So the Safe Step Act, for example, is a step therapy protocol which mandates reasonable and clinically informed process to grant the exceptions, but it is at least giving the chance to convince the insurance companies why those patients are not really following the guidelines for their treatments. So the key takeaways is we have a distinct subset of multi-failure psoriasis patients that are characterized by early onset disease, long duration, and significant comorbidity burden, particularly with psoriatic arthritis, diabetes, and cardiovascular disease. The most common reason for switching is usually secondary failure. Combination therapies require further studies but are being trialed. And systemic research registries and legislative advocacies like the Safe Step Act are essential to understand this population and move further. And so we do need to identify also the predictive biomarkers in the future. Hopefully, we will have an ability to genetically profile patients. So we're talking about the exterior, for example, that Dr. Azzam talked about with looking into the nails. We also want to look deeper into the genetics. So we are going from exterior to interior in all our dermatological studies to help identify and profile our patients. And with that, I also would like to share that I am very, very proud to advocate for Riyadh to be hosting the World Congress of Dermatology in 2031, inshallah. And we do look forward to all of you joining us, inshallah. So here you can see that my 3 children, if they are clear, they're on this beautiful landscape in Riyadh. It's called the Edge of the World. And every time I see this picture, I do think, like, when you're out on the edge of the world, you really see how the sky's the limit. And it gives you opportunities for the future, and that you know that the future is bright, inshallah, for all our patients in dermatology. Thank you so much.
Excellent, Nadia. Thank you very much for sharing this experience. Now we reach the conclusion of this first Saudi African Summit. I'm truly inspired by what we have collectively shared. This has been a vital forum of clinical experience, medical insight, eye-opening. These presentations we had today represented a profound generosity of knowledge and experience. They were truly heartwarming, eye-opening. Our esteemed presenting speakers, thank you. You have taken time from your demanding schedule, not just to share slides, but to share hard-won clinical wisdom. Your contributions are the very heart of this summit, and it's really what makes us stronger, what makes us together, what unites us, is sharing these experiences. To every participant who joined us in this morning with a spirit of learning and collaboration, thank you. The quality of our shared knowledge is measured by the community it builds. And a special acknowledgement must go to Dr. Najib Doss for his pivotal role in convening this unique assembly of medical minds. Your vision in organizing this clinical exchange is deeply appreciated. Now, as we conclude, let us view this not as a finale, but as the establishment of a critical professional network. This summit is the first of many to come, and it's our hope and intention to make this clinical knowledge sharing a sustained tradition, where we can continue to learn from each other's experience, tackle shared health challenges, and foster a legacy of medical excellence. The connections we made here today are very powerful prescription for our collective future in healthcare. Thank you for your invaluable participation, professional fellowship, and stay safe, continue your vital work, and we look forward to welcome you all in Riyadh in 2031, where our slogan is United for Skin Health. Thank you very much.